Hi, good morning, everyone. Welcome to 145th CMAAO weekly session. We are meeting on 27th of May, 2023, 9:30 a.m. Indian Standard Time. We are talking about optimal liquid management, the new targets. If anybody who's watching live would like to join the session, can come on the Zoom meeting ID at 818-859-11572. Today we have Dr. Vitull K. Gupta. He is a health and human rights activist. He's an honorary teacher faculty at AIIMS Bathinda. He's a consultant at Kishori Hospital and Diabetic Care Center, Kishori Ram Road, Basant, Vihar, Bhatinda in Punjab. And I would like to invite him for the one of the important sessions. Sir, over to you.
Thank you, Dr. Saurabh, and thank you, IJCP, as well as Heart Care Foundation of India, for giving me this opportunity to speak amongst doyens of academics. Thank you very much. So I will request you to put up the slide so that we can start the session.
Absolutely.
So this
Can you see the slides?
Yeah, this is my brief introduction. Next slide, please.
Okay.
So thank you very much. So today's topic is optimal lipid management, the new targets. So I must thank IJCP as well as Heart Care Foundation of India for choosing this rather important topic, because the guideline-based medical therapy, where lipids management is very important, is being neglected in primary healthcare. So that is why this topic gains importance, to generate awareness among common people as well as, more importantly, among the doctors for optimum lipid management, which is very important in controlling the cardiovascular disease mortality as well as morbidity. Next slide. So I start this lecture with tributes to my father, late father, Comrade Prakash Gupta, and my friend, teacher, mentor, Dr. Gurpreet Singh Wander and Dr. Paramjeet Singh Aulat. Next. Coming on to the topic. So I will be basically talking about Indian guidelines as well as Indian scenario. India is experiencing an epidemic of atherosclerotic cardiovascular disease. Coronary artery disease manifests almost a decade earlier in India than in Western countries. That is why we are not talking about Western guidelines, because they are different in Indian scenario. CAD is increasing most rapidly among patients younger than 40 years of age in India. About 10 to 25% of myocardial infarctions in India occur before the age of 40 years, and more than 50% of coronary artery disease associated deaths in India occur before the age of 50 years. So these are the important differences from Western nations, and that is why we need to focus more on cardiovascular disease mortality as well as morbidity. Next. Multiple risk factors. The conventional risk factors like smoking, sedentary lifestyle, obesity, hypertension, and diabetes are important contributors to atherosclerotic cardiovascular disease, but dyslipidemia is a major condition for atherosclerotic process which needs to be addressed, and that is what we are going to do today. About 80% have at least one lipid abnormality. Next. So prevalence of dyslipidemia is very high in Indians, and most have atherosclerotic dyslipidemia, which further increases the risk of atherosclerotic cardiovascular disease. And that atherogenic triad is consisting of elevated triglycerides, low HDL-C, and normal or mildly raised LDL-C. and it contributes to residual risk of atherosclerotic cardiovascular disease even after achieving the LDL-C goals. So that is why we need to address the dyslipidemia as a whole, including in elevated triglycerides and normal or elevated LDL-C. We cannot do much about low HDL-C. Next slide. Because of the unique feature of dyslipidemia and atherosclerotic cardiovascular risk in Indians, the Lipid Association of India proposed updated risk stratification for LDL-C goals based on major atherosclerotic cardiovascular disease risk factors, namely age, family history of premature atherosclerotic cardiovascular disease, smoking, hypertension, low HDL-C, and other non-conventional risk factors include coronary artery calcium score, CIMT, the little PA, fasting glucose, waist circumference, and highly sensitive C-reactive protein. So these are the non-conventional atherosclerotic cardiovascular disease risk factors which we need to consider while treating dyslipidemia as well as atherosclerotic cardiovascular disease. Next. So in 1961, the most important Framingham Heart Study investigators identified serum cholesterol as one of the risk factors for CAD. Since then, numerous epidemiological studies and RCTs have established that an elevated LDL-C is a major contributor of atherosclerotic cardiovascular disease. As a consequence, lipid management has become a central objective for prevention of CV events and most importantly, focusing on LDL-C levels. Next. Over a period of time, an increasing scientific evidence has led to general consensus, lower is better goal for LDL-C. This has led to concerns about risk of intensively lowering LDL-C, and many people and researchers have raised this issue that lowering LDL-C may affect the biology of the health as such, affecting the cellular cell wall, which is most important. But evidence today indicates no significant harm from either very low levels of LDL-C or from drugs used to lower the LDL-C levels. Aggressive LDL-C lowering is safe and effective strategy. That is an evidence-based statement and journal consensus among the researchers. Next. So why we are coming to this conclusion? Because naturally occurring low LDL-C levels are present in number of populations, and virtually all of us were born with LDL-C less than 40 milligram per deciliter. Lifelong LDL-C levels of less than 50 milligram per deciliter have been observed in hunter-gathering societies without evidence of any health risk. No major adverse outcome was associated with genetically inherited conditions with low LDL-C, while atherosclerotic cardiovascular risk was low. Next. So Indian consensus statement by Lipid Association of India, because that is the most important association which is related to the lipid management, and they are adopting the international guidelines suited for Indians. The Lipid Association has provided flexibility by allowing the final decision for the patient to be taken by the physician. That is where the personalized medicine comes in. And LAI released consensus statements in 2016, updated in 2018 and 2022 based on CV risk factor assessment, treatment goals and targets, treatment recommendations, follow-up monitoring, and safety assessments. So these are the 5 areas where LAI has based and issued the consensus statement in 2020. Next. The Indian specific guidelines and challenges, why they are important? Because Indian population has different genetic, phenotypic, cultural, socio-economic variability as compared to Western population. So that is why it emphasized the need for country-specific recommendations. LAI has proposed lower LDL-C goals for Indians based on recent randomized trials that has shown further reduction in CV risk by non-statin drugs. So basically, both the Western guidelines, LAI has considered the Indian data, which may be not as sufficient as it needs to be, but they have proposed the lower LDL-C goals as compared to the Western population. Next. So the focus is on LDL-C as primary treatment target and non-LDL-C, HDL-C as a co-primary target. So we are focusing more on LDL-C, but not ignoring non-HDL-C and considering it as a co-primary target. Next. So if we talk about the new targets, since 1980s, the LDL-C in CV outcome studies has dropped steadily from more than 150 milligram per deciliter to about 70 milligram per deciliter and lower in latest combination trials, especially in Indian setup. So this slide beautifully depicts the lowering of the lipid targets, especially LDL-C, since 1980s, and various trials have been done, and they are proposing the lowering of LDL-C levels. That is why we are discussing the lipid management, the new targets. So what we are considering in 2023, we were not considering that in 1980s. So the evidence suggests lowering of LDL-C is translating into mortality and morbidity benefits as regard to the cardiovascular diseases. Next. So the treatment approach have changed from high intensity statin concept to high intensity lipid lowering strategy. So there is a major shift. 10 years back, we were talking about high intensity statin concept, and now we are talking about high intensity lipid lowering therapy. Achieving new goals will require add-on non-statin LDL-C lowering therapies like ezetimibe, PCSK9 inhibitors, and recently introduced bempedoic acid. Next. So we have also categorized the patients as compared to the risk that depends upon risk factor markers. The major ACD risk factors, I will not go in details for paucity of time. The other high risk factors and moderate risk, non-conventional risk factors are considered to risk stratify the patients into low risk, moderate risk, high risk, and very high risk. So this was proposed in 2016. But now, next slide. Now we are considering the risk groups as low risk, moderate risk, high risk, and very high risk as we were previously considering. But now LAI has added an extreme risk group, that is category A and category B. So these risk groups are really important, as we will discuss in future slides, that the statin therapy or lipid lowering management therapy, the goals are different from now extremely risk group, that is category A and category B. So this risk stratification is important to modulate or to personalize the risk assessment considering the lipid lowering management. Next slide. So this is very important. Once we go for lipid management, what do we do? The Lipid Association has suggested the lipid profile assessment, especially focusing the Indian population, that on first visit, either you get fasting lipid profile or you get non-fasting lipid profile. But on second visit, if we are getting fasting lipid profile in first visit, then we go for non-fasting lipid profile on second visit and vice versa. So that means that each and every patient should get a lipid fasting profile as well as not lipid fasting profile, because in Indian subjects with dyslipidemia, both fasting and non-fasting lipid profile should be known. If fasting lipid profile or direct LDL-C measurement is recommended to judge whether LDL-C goals have been achieved and to determine the need for additional LDL-C lowering therapy. Non-fasting lipid profile is required to determine the postprandial hypertriglyceridemia. So it is very important in Indian setup for a patient or for a doctor to recommend both fasting lipid profile and non-fasting lipid profile depending upon first visit or second visit. Next. So what are the advantages? So this needs to be known why Lipid Association has suggested the fasting as well as non-fasting lipid profiles. So if we consider fasting lipid profile, it is considered to be gold standard for atherogenic risk assessment. It is important for highly sensitivity to detect triglyceride level, especially in patients with insulin resistance. So Indian population are greatly insulin resistant population. Preferable in certain high-risk patients for whose severe triglyceridemia for exact diagnosis and therapeutic monitoring. Preferable when non-fasting triglyceride is more than 440 milligram per deciliter, to be considered after 2 to 4 weeks when non-fasting triglyceride level is more than or equal to 200 milligram per deciliter. So these are the advantages of fasting. And if we consider advantages of non-fasting lipid level measurement, so it is helpful in detecting the plasma lipid level of both atherogenic lipoproteins of hepatic descent and those originating from intestine, because it is non-fasting after meals. So it is detecting the atherogenic lipid lipoproteins originating from intestines also. Preferred in patients with diabetes due to increased risk of hypoglycemia with fasting. Low density lipoprotein cholesterol can be precisely assessed using modern techniques. So this is important on the basis of patient's convenience. So it reduces the patient's barrier to testing, increased patient's convenience and compliance, decreased strains on laboratory facilities. So these are patient related advantages for non-fasting lipid assessment. Next. So once we have considered the fasting and non-fasting, we need to have the cutoff for lipid parameters for fasting as well as non-fasting. So total cholesterol is same for fasting and non-fasting, but triglyceride is different. Fasting is more than 150 and non-fasting is more than 170. Again, HDL-C is same. Non-HDL-C has a difference of 5 milligram per deciliter and LDL-C is same. And similarly, the remnant cholesterol is a little bit different, and lipoprotein A and apolipoprotein B, the cutoffs are same. So we need to know these cutoffs when we are suggesting fasting as well as non-fasting during the first 2 visits for the patients. Next. So coming on to the management. Management, as always in almost all the non-communicable diseases, consist of non-pharmacological therapy and pharmacological therapy. Next. So non-pharmacological therapy, once we consider patient as dyslipidemic or the non-communicable disease, lifestyle management should continue to form the basis of all lipid reduction therapies at any time. Healthy behavior interventions are vital for diabetes management and CVD protection strategies, and that is true for all non-communicable diseases. Essential considerations to improve overall lipid profile and glycemic control, along with hypertension, obesity, it reduces the CVD risk and include accomplishing healthy weight, aerobic activity level, implementing the energy restricted diet, well balanced diet, moderating alcohol consumption, and smoking cessation. So that includes the basis for non-pharmacological therapy. Next. So once we consider the pharmacological therapy, again we need to know the treatment goals and when to start statin. So this is a beautiful slide by the Lipid Association of India, which tells us about the LDL-C and non-HDL-C goals, as well as to consider the drug therapy at what levels. So this is again on the basis of risk stratification. So at the start, the extreme risk group A category, the LDL-C, the optimum treatment goal is less than 50 and non-HDL-C goal is less than 80. And consider drug therapy if the LDL-C is more than 50 or non-HDL-C is more than 80. So similarly, extreme risk group B category is the most important. The goal has been decreased to 30 and non-HDL-C is goal reduced to 60. And similarly, consider drug therapy if the LDL-C level is more than 30 and non-HDL-C level is more than 60. So this goal is reducing as the risk is reducing, and in low risk for Indian patients, low risk patients LDL-C less than 100 and non-HDL-C less than 130 is the treatment goals, and we consider that drug therapy if it is more than 130 LDL-C and more than 160 non-HDL-C. So this slide gain important and tells us about the strategy that these are the new treatment goals for Indian population as suggested by Lipid Association of India. Next slide. So we need to consider what is different in Indian setup as far as the treatment goals are considered. So these are the treatment goals for Western population, a consensus statement by American Association of Clinical Endocrinologists and American College of Endocrinology. These similar statements have been issued by AHA and ACC also. So that is where the LDL-C goals are high risk, very high risk, and extremely high risk. So if we see this slide for extremely high risk, there in Indian population, we consider it to be less than 30, but here it is 55. So all the other goals are a little bit higher as compared to the Indian population. That is why we are discussing that Indian atherosclerotic cardiovascular disease population is a little bit more risk than the Western population. So Indian population needs to have lower goals of LDL-C as well as the non-HDL-C levels as compared to the Western population. Next slide. So once we have considered the goals, then instead of text, I want to follow this flow graph to discuss the treatment strategies. In low risk group, that is, if it is LDL-C level is more than 100 milligram per deciliter, we go by lifestyle interventions in low risk group. And if the LDL-C remains more than 100 milligram per deciliter, we add moderate statin therapy to achieve the LDL-C goals of less than 100. So similarly, in moderate risk group, we follow the same pattern. But if the LDL-C goals are not achieved, we go with aggressive lifestyle intervention, and the statin therapies highly intensify statin therapy. But in low risk group, we were considering low or moderate intensity. In moderate group, we are considering high intensity therapy to reach the target levels of less than 100 milligram per deciliter for LDL-C. And if we are considering high risk group, there the LDL-C goal, if it is more than 70 milligram per deciliter, we add the moderate intensity therapy. And if the LDL-C remains more than 70, we shift it to high intensity statin therapy to reach the target level of less than 70 milligram per deciliter for LDL-C. So that is how we go for management for low risk group, moderate risk group, and high risk group through achieving the target levels of LDL-C less than 100 and less than 70. with high intensity therapy if the moderate intensity therapy and lifestyle modifications are not achieving the goals. Next. So similarly, in very high risk group, we want LDL-C levels to be less than 50, and we start therapy if the levels are more than 50 milligram per deciliter for LDL-C. We start straightway with high intensity statin therapy, and if LDL-C remains more than 50, we add ezetimibe 10 milligram and again assess the LDL-C. If it is still more than 50 milligram per deciliter, we add bempedoic acid, bile sequestrant, and or PCSK9, that is individualized according to the physician's choice, because these are expensive drugs. So that depends upon patient's compliance also. But we need to reach the target LDL-C levels of less than 50 milligram percent in very high risk group. And extremely high risk group, category A, we start the same way, but here high intensity statin therapy is straightway we add ezetimibe to achieve the goal of less than 50 and optimum goal of less than 30. So in extremely risk group category A and category B, we need to reach the goal of LDL-C levels of less than 30 or equal to 30 milligram per deciliter, and we straightway add high intensity statin therapy with ezetimibe. If the goals are not achieved, we add bempedoic acids or PCSK9 to achieve the goal. So in Indian population, from mild risk group to extremely risk group, we have three categories, that is less than 100 milligram per deciliter, less than 70, and less than 50 and less than 30, depending upon the risk stratification. And goal has to be achieved. If not with only statin, we need to add ezetimibe, bempedoic acid, PCSK9 to achieve the goal. So that is why we are considering from the statin-based therapy to lipid-lowering based therapy, because addition of non-statin drugs are extremely important to achieve the goal of less than 50 or less than 30 milligram percent of LDL-C levels. Next. So what we consider as high intensity therapy or moderate intensity therapy, statin therapy, high intensity statin therapy, we consider atorvastatin and rosuvastatin in the dose of 40 to 80 milligram, rosuvastatin for 20 to 40 milligram. And in moderate intensity therapy, the other drugs can be added. So in high intensity therapy, atorvastatin and only rosuvastatin are added, and rest are considered for moderate intensity therapy. Next. So coming on to triglyceride levels. So this is important for atherogenic dyslipidemia. So we generally follow the classification of TG levels based on fasting lipid profile, and as shown that optimum is less than 100, normal is less than 50, borderline is 50 to 199 milligram per deciliter, high is 200 to 449 milligram per deciliter, and very high is considered when the triglyceride levels are more than 500 milligram per deciliter. So this is how we classify the fasting triglyceride levels. Next. So again, I will take the help of this flow chart instead of text to discuss. If the triglyceride levels are 150 to 199, we along with this measure LDL-C levels, calculate non-HDL-C, and assess the cardiovascular risk as far as atherosclerotic disease is concerned, and institute lifestyle interventions in the form of low-fat diet, avoiding refined carbohydrates, weight reduction, exercise. So that is the conventional risk factor we need to control, as well as, more importantly, control the secondary causes for triglyceridemia. So if increased level of LDL-C levels are found, increased non-HDL-C levels, and high atherosclerotic cardiovascular risk, we add statins plus ezetimibe, may or may not be depending upon the LDL-C, to achieve the targets what we have discussed depending upon the risk stratification, whether it is mild, moderate, high risk, or extremely high risk category A or category B, and we add statin azitamide if triglyceride or non-HDL-C levels are still high. Then we consider specific therapy consisting of omega-3 fatty acids or fibrates. And similarly, if the triglyceride levels are between 500 to 999, we straightway go for risk stratification for pancreatitis as well as atherosclerotic cardiovascular disease. And similarly, aggressive lifestyle interventions are instituted, which was not when the triglyceride levels were low. And we add fibrates, omega-3 fatty acids, and consider similarly addition of statins, azitamides to achieve the LDL-C levels. And if they are not achieved, we can add bempedoic acid and PCSK9, as we have discussed in the risk stratification slide, if the risk is category A or category B. And if the triglyceride levels are still very high, then we need to have genetic counseling, testing, and newer drugs may be required. And so the specialist care is needed to assess and to institute personalized therapy according to the TG levels. Next. So, my dear friends, the take-home message is lipid-lowering therapy is key to improving the CV outcomes in all the patients of non-communicable diseases, especially in diabetes. Lifestyle intervention in combination with high-intensity statin and non-statin therapy are first-line management strategies to achieve LDL-C goals. And because of that, we have changed the strategy from high-intensity statin therapy to concept of high-intensity lipid-lowering strategy, because they will need additional non-statin therapy to achieve this very stringent LDL-C goals. Next slide. To summarize, I have taken this slide from Management Strategy of Indian Population from RSSDI guidelines. This is from diabetic dyslipidemia, but it fits into all the type of lipid management. That is, first we need to risk stratify for atherosclerotic cardiovascular disease. Then we need to set up the lipid goals as far as depending upon the atherosclerotic cardiovascular disease risk, whether it is mild, moderate, high risk, extremely high risk, category A or category B. And depending upon that high risk, we need to initiate and escalate the lipid lowering therapy, as we have discussed in the flow chart, starting with moderate intensity statins, high intensity statins. If the lipid LDL-C level goals are not achieved, we add azitamide. And if still we need to add PCSK9 or bempedoic acid, so we should add that to achieve the target goals, what we have discussed in the previous slides. And for triglycerides, we need to stratify again. And depending upon the LDL-C levels, we add statin, bempedoic acid or PCSK9. And for triglycerides, fibrates, seroglitazar or omega-3 fatty acids are important drugs to control triglycerides. And both triglycerides and LDL-C levels form a constellation of atherogenic dyslipidemia, because nothing much can be done to increase the level of HDL-C. So that is why we need to focus on achieving the target goals for LDL-C as well as triglycerides. Next slide. Thank you very much. With that, I invite you all to 10th Annual Conference of Association of Physicians of India, Malwa branch at 21st to 24th September 2023 at Bathinda. Thank you very much.
Thank you, Dr. Gupta. This is an excellent presentation and a very insightful knowledge for all of us. I would like to now open the forum for the question answers. Dr. Monica.
Dr. Gupta, thank you for a fantastic presentation, and I think is a great reminder of measures that we can take on a preventive scale went through a lot of algorithms, and being of the Indian diaspora outside of India, I feel that the Lipid Association of India guidelines actually should apply to all of us, that the guidelines, we should be looking at the guidelines of the country that we live in, but also looking at what the LAI say. LDL of 70 with no risk factors and an LDL-C of less than 50 with risk factors. Very ambitious, especially for countries that for the United States, that's a lipid target, an LDL target of 100. There are no guidelines right now for the Indian diaspora outside of India. And I was wondering, has there ever been any conversation about what are we looking at for targets of people who are first generation or new immigrants, Indian immigrants in other countries to maintain our cardiovascular health and to look at preventive care?
So this question is directed to me?
Yes.
Or this is a comment? So basically the Indian data is still, there is paucity of Indian data. What LAI has incorporated the data from the Indian diaspora living in Western countries, how they behave. And still there is no data how the second generation is going to behave. But still they provide this insight that if a patient of Indian origin is living outside, the LAI guidelines should be incorporated, because studies have shown increased morbidity and mortality of patients of Indian origin. So somehow genetic predisposition is there, and until and unless there is crossbreeding and second generation Indians are there who have married the Western population, and there is mixing of genetic pool, they may have the same risk factor or same risk profile as the American population, but still we need to have sufficient data to show that the second generation or third generation Indians have got the same risk factors as Indian population, or the risk factors have decreased, but the India has got definitely genetic predisposition. That is why the atherosclerotic cardiovascular disease has got different profile in Indian population as compared to the Caucasians.
I think that's fantastic. I even think that applies even for diabetes as well. And
yes,
for,
definitely.
Thank you very much. Very, very knowledgeable.
Because if we consider the visceral fat also, we consider Indians as thin, fatty population as compared to the Caucasians. So we have more of visceral fat rather than subcutaneous fat, and Indians may look thin, but still they have more of atherogenic dyslipidemia as compared to the Western population.
Hi, may I say something?
Yes, sir, definitely.
Hi, I'm Dr. Chung from Singapore. It's very interesting because we have an Indian population in Singapore. And our Indian population in Singapore is 7% of the population, but 15% of all heart attacks.
Yes, definitely. So that substantiates my, this LAI that Indians have got different genetic setup. So until and unless, the second or third generation Indians may mix up with the same population, reduces the risk factor for cardiovascular disease, remains to be seen. And more studies are needed to that conclusion.
Our diabetic rate is also similar. They are double the diabetic rate of the other populations in Singapore, which are the Chinese and the Malay population.
So that is true for all non-communicable diseases. You take hypertension, if we consider AHA-ACC guidelines of less than 30, less than 80 for hypertension cutoff, almost 56% of Indian population becomes hypertensive. And younger patients are having hypertension, and more of CVD risk factors are there, and more severe hypertension is in Indian population as compared to the other population. But that is not much of a difference as far as South Asians are concerned. But among South Asians also, Indians have got peculiar risk factors that make them susceptible to all non-communicable diseases, whether it is obesity, diabetes, hypertension, the cardiovascular diseases are more in Indian population.
The other interesting thing that we are doing here in Singapore in our practice is that we have quite a number of patients on PCSK9 inhibitors, including inclisiran, and we see that the LDLs can come down to as low as 10.
Yes.
And at that level, we actually follow up with, for example, carotid ultrasounds and so on, and we actually see regression of carotid plaques.
So definitely, similar studies have been done in India also, because in India there is diverse population and most of the people may not afford PCSK9 or bempedoic acid. But in corporate hospitals, a lot of studies have been done where they have shown reversal of the this thickness or the lipid profile once they are decreased to, like you are telling, less than 10 mg/%. Definitely, the Indian studies have also come up showing this, with especially PCSK9.
Yes, very. We agree. And the other interesting thing is because we're particularly targeting those people with cerebral atherosclerosis, because there's almost no options when you have stenosis of your circle of Willis or your intracranial vessels. So the PCSK9s have been very powerful in this aspect. And we also see that the difference between doing a coronary stent and doing a PCSK9, we believe is time, meaning that this could be a powerful challenge to the stents. Thank you.
Definitely interesting finding.
Thank you very much.
Thank you.
Thank you, Dr. Chong. He was a chair for CMAAO. Can I invite anyone else has a question? Can I invite them? So there was a question on the Facebook which says, can you throw some light on LDLC and pregnancy, during pregnancy?
So during pregnancy, LDLC, I think the studies are very sparse. So LDLC lifestyle modifications definitely, but other drugs may not be useful or may not be used in pregnancy for that. So LDLC levels can be reduced with intensive lifestyle modifications. Definitely risk factor profile is very, very important. How patient is at risk. But definitely we can wait and watch for 3-4 months. After delivery, we can institute the therapy as guideline-based therapy.
And do you also recommend anything in relation to the diet modification, like any specifics?
No specifics in pregnancy. Diet is very, very important. That patient gains weight according to the trimester. But still, if we go for refined sugar restriction, weight control, if patient is obese, we need to control the weight, and exercise is very important. So exercise with the consultation of a physician, that how much exercise is beneficial. Definitely pregnancy is a very tricky issue. So we can have certain guidelines, but it has to be personalized medical therapy according to the patient, considering many factors, patient's health, the previous obstetrical history, the fetus weight. So we need to consider all the things before any lifestyle modifications or any drug therapy to be instituted, keeping in risk profile in mind.
So another comment where it says there are a lot of people who are eating only healthy food. It still causes a very high cholesterol. And is that genetic or is that other reasons? I'm sure that you have shared that slide where a lot of other reasons were being shared of high cholesterol. So that covers the question, but if you still want to add something.
No, definitely. You will find so many thin people with high cholesterol. So basically it is genetic predisposition, how the body is going to store the fat. So again, secondary causes need to be ruled out, and all the family members should be screened for hereditary dyslipidemias. Hereditary triglyceridemia is very important. So that is one factor where the premature cardiovascular death in that family will stimulate to go in for lipid profile for all the family members to detect the hereditary familial dyslipidemias.
Okay, and
Okay, Dr. Pillai here. It has been very, it has been a very useful presentation. We learned a lot from that. Yeah. So the question is, as a neurosurgeon, we do find patients with stroke. The lipid values may be normal, but carotid stenosis may be there, maybe 30% or 60%. So even when the lipid values are normal, is there a role for statins in these
Yes,
patients?
sir. Definitely. That is what the last slide shows, that risk stratification. If some event is occurring at supposing 100 milligram of LDL-C, we need to reduce that by 30%. And if there is other risk factors, we need to reduce that by 50%. So that is the risk stratification. Because that level has caused the problem, we need to reduce that. So normal value is according to the risk stratification. What we have discussed, that atherosclerotic cardiovascular disease or cerebrovascular disease risk factors are there. So we definitely need to reduce. Depending upon that, we can institute moderate statin therapy, high intensity therapy, and if it is not controlled, we must add ezetimibe, bempedoic acid, or PCSK9. As the other chairperson has told us, that they have found regression in cardiovascular disease as well as cerebrovascular disease with PCSK9. So definitely we need to have statin therapy or non-statin therapy to achieve that goal.
Thank you. One observation is the Indian diaspora, more than, of course, the genetic factors do exist, but then their food habits never change. Even if they are in America or Canada, they still have the old food habits, particularly the first generation Indian migrants. Do you think that's also a factor?
That is why lifestyle modifications form the basis of all the preventive therapy as well as prevention, primary prevention, secondary prevention, and tertiary prevention. At all levels, the basis is lifestyle modification. That is diet, exercise, weight, diabetes control, hypertension control, smoking cessation, alcohol moderation. So we need to have that. So that is how the pharmacological therapy is going to be effective.
Thank you.
Sir, can you give a small point on young hypertension and young high cholesterol under the age of 18, and how often it should be tested?
So the guidelines based is above 18 years. So that comes under pediatric group, but I think the LAI has proposed the guidelines for age group above 15 years. So similarly, if patient is hypertensive, we need to have the same guidelines, that is starting with ACE inhibitors or receptor blockers, with calcium channel blockers, with diuretics, and fourth is beta blockers. So that is if we are not able to control with all these three drugs. And the target levels for Indian population without any risk factor is less than 140/90, and with risk factors, it is less than 130/80. So that is for all populations. Even before that, above age of 85 years, it was considered that a little bit more systolic blood pressure is needed. But now across the age, so this is the guidelines for hypertension. And definitely it should be personalized. If person is having some hypostatic hypertension, postural hypertension, or feeling weak. So we can set the target a little bit higher in older population, but we need to follow the guidelines that is less than 140/90 in all populations without risk factors, with risk factors, especially diabetics, less than 130/80.
Thank you so much. I don't think there are any more questions. Do we have any questions from the audience over here? Or otherwise, we will quickly wind up the session. We are right on time today. Whenever I see time, I need to be careful with Dr. Monica. So, she's joining us from US, so it's pretty late for her.
Definitely, definitely.
Anybody has any questions? It is a wonderful session. I think this is a kind of a session we need on a regular basis. I know there are a lot of questions from the audience in a retail, regular audience who wants to know what is going on with the cholesterol. I still remember I have a friend who is probably, I don't think I have ever seen any slim person than him. And when he checked his cholesterol level, there was a comment saying it was pretty high, including the BMI. And he asked me a question, where do I remove my fat from? I don't have anything on the body.
So that is where comes the importance of visceral fat. If he gets his visceral fat done, it is definitely going to be high. So
Absolutely.
he must, convert the visceral fat into good fat. So there is good fat, there is bad fat. So there comes the importance of exercise and insulin resistance.
Okay, Dr. Gupta, thank you for a wonderful session. I think it was a session which made our weekend better, and I would request everyone to go and exercise. I think that is one of the best thing you can reduce your cholesterol without medicine, and obviously eat healthy. And if you still think that you need a doctor, please go and consult your respective doctors. If you have any questions from Dr. Gupta, please write it to me. I will ask him directly. And we also invite him for one of the follow-up sessions going forward. With this note, I would like to close the session. Thank you, Dr. Gupta. Thank you, everyone, for joining in.
Thank you, Dr. Saurabh, and IJCP as well as Heartcare Foundation for this excellent platform to interact with a lot of good and academically oriented people. Thank you very much.